Good evening, everyone. Thank you so much for joining us tonight for this edition of the Scleral Lens Education Society webinar series. Tonight, we present scleral lens fitting challenges with the esteemed Greg DeNaeyer and Jason Jedlicka. So I want to introduce our speakers tonight. First, we'll have Dr. Greg DeNaeyer, who practices at Arena Eye Surgeons with an emphasis on specialty contact lenses. Dr. DeNaeyer was a co-founder and past president of the Scleral Lens Education Society and is a fellow of the American Academy of Optometry. He's a contributing editor for Contact Lens Spectrum and a contributor to review of cornea and contact lenses and optometric management. Currently, his primary research is focused on specialty lens designs in Corneo-Scleral Topography. We also have Dr. Jason Jedlicka, who is an associate professor at Indiana University School of Optometry and the director of the Cornea and Contact Lens Service. He's a diplomate in the American Academy of Optometry's Cornea and Contact Lens and Refractive Technology section, a past president of the Scleral Lens Education Society, and a fellow and board member of the Contact Lens Society of America. He's contributed to multiple textbooks as an author on the topic of GP and scleral lenses. He's the developer of the Zen lens, the Zen RC scleral lens, and is a consultant to Bausch & Lomb and Oculus. And with that, I will turn it over to Greg.
Thank you very much, Drew. I appreciate it. This is Greg DeNaeyer, and thank you for joining Dr. Jedlicka and I tonight for our webinar. We do have some objectives, and I'm going to start out the webinar by talking about learning to identify and troubleshoot landing zone misalignment. And then Dr. Jedlicka will discuss learning about how lens diameter can affect scleral fit. And then I'll circle back around and end with learning to identify and fit common scleral obstacles. Well, by far the most common complication that we see with scleral contact lens fitting is when we have a misalignment or a mismatch between the landing zone of the scleral contact lens and the anterior ocular surface. And to better understand the scleral surface, in 2017, the Scleral Shape Study Group published a paper in the Journal of Contact Lens Research and Science with the objectives to classify scleral shape. So this was a retrospective study looking at 152 eyes of prospective scleral lens patients. And each of those eyes underwent Corneo-Scleral Topography. So we were using an instrument that not only measures the corneal surface, but also measures out onto the scleral surface. And effectively what we found was that there was 4 distinct types of scleral shapes. And when we combined those classified shapes with modern scleral lens design, what we determined was that 6% of the eyes would be best fit with a scleral contact lens that had a spherical landing zone, 30% would be best fit with a toric landing zone, and then the majority, 65%, would be best fit with a quadrant-specific landing zone, or what we would term as a free-form, fully customized scleral lens back surface. Well, just a couple weeks ago, Dr. Muriel Shorniak and Dr. Jennifer Hawthorne gave updated results on the most recent scleral lenses in current ophthalmic practice and evaluation. This was the 2020 version. They had previously done a 2015 study as well. But what I found interesting was that when they looked and asked practitioners who fit scleral contact lenses, what % of their fits have different landing zone designs, what they found was that 40% of the fits ended up being a spherical landing zone. 48% these practitioners were using toric landing zones, and then only 12% quadrant-specific or impression-based landing zones. And I think it's interesting if we then pull up our data from our scleral shape study and compare those numbers with what practitioners are in the clinic fitting, we don't see a great correlation, especially in this spherical category. And part of the aim of this lecture really is to try to get you to recognize and to use more customized scleral contact lens designs, because ultimately you're going to more effectively fit a majority of your patients. And we'll go through very specific case examples. Now, there's really 4 different types of landing zones. We have the spherical landing zone, toric landing zone, quadrant specific landing zone, or freeform lens design. And I think as we move through those types of landing zones, we have to try to understand what threshold in microns we need to have in order to use a specific design. And when we look at the various scleral studies that have looked at scleral shape and also just basing this on clinical experience, what we really find is that the micron threshold for differentiating different landing zone designs with regards to scleral shape is around 200 microns. And let me go just through a case example for a sclera that's toric. So if we know that we have a sclera that's toric, but we're able to measure that scleral surface and determine that the difference in microns as we go around the scleral surface is less than 200 microns, then this probably isn't clinically significant enough to warrant a toric landing zone design. And in fact, actually, this patient may be best fit with a spherical landing zone design. But as we reach that 200 micron threshold and go higher, for example, 200 to 300 microns of scleral toricity, which I would consider moderate scleral toricity, or even greater than 300 microns of scleral toricity, then these patients definitely require a toric landing zone of the lens to be best fit. Well, starting off with the spherical sclera, there's 2 main ways that we can determine if the patient's eye is spherical. One way is just to use our diagnostic lenses, and most of the fitting sets that are available out there do have a majority of the lenses within the set having a spherical landing zone design. So we can put these on and evaluate the lenses, or we can use something software-based. And when I mean software-based, this would where we would measure the eye with profilometry, and that could include Corneo-Scleral Topography or Scheimpflug imaging, or we can use impression-based measurements. So we said that with our scleral shape study group that this, using a spherical landing zone design would be about 6% of our fits, or 6% of eyes. So if you have a patient and using diagnostic lenses and you put a spherical landing zone design on their eye, and that lens exhibits even alignment and centration, then I think you can conclude that this patient does have a basically spherical sclera. And so if you can use a spherical landing zone. We have to be a little bit careful though, because those types of designs don't have any rotational stability. And so if you're going to add on either front surface toricity or a localized vault, then the lens has to be ballasted. And each manufacturer may do that a little bit differently, but a common way is to use what we call double slab off. And that'll just get the lens to rotationally stabilize so we can add on some of these other features. As we said, beyond using just our spherical landing zone diagnostic lenses, we could just measure the eye. So this is a scleral elevation map of a patient. The center red circle is a cornea. We're going to ignore that. So all the color around the cornea is the sclera. And when we quantitate that map, that scleral map, what we see is that the difference in sagittal height in circumlinear fashion is less than 200 microns of change. And so this sclera we would consider spherical in nature. Well, next, looking at the toric sclera, there's been a big push towards toricity, and so a lot of the companies now offer toric diagnostic lenses within their fitting sets, and those are quite useful. And again, just like our spherical scleras, we can also use software-based analysis to determine a toric sclera. Let's look at a case example with trying to determine toricity on a patient with a toric sclera. This is a patient who had a penetrating keratoplasty. She had difficulty with corneal GP lenses. To your right, you see her corneal elevation map. And to start, I actually put on a a 16 millimeter scleral lens with a spherical landing zone. And what I want to point out here is that in the superior and inferior quadrants, we do have alignment of the lens on the eye. But as we move out towards the periphery, we start to see compression. And the key here is that not only do we see this compression, but we have the symmetric compression. And so we can really conclude that this patient probably has a toric sclera. From that point, if you do discover that, then the best next move is to go to your fitting set and apply a toric landing zone lens, a diagnostic lens. And if you're in doubt, I think 200 microns is a good place to start, which is what I did. So if we look to the right, this is a similar lens, but has a toric landing zone. And you can see from this photo that we eliminate all of the horizontal, the nasal and temporal compression that it was exhibited with the spherical landing zone. Remember that toric landing zones are going to be needed about 30% of the time. The threshold value is about 200 microns, and that's always it's also a good place to start if you're unsure how much toricity the sclera has. The toric landing zone will help the lens to rotationally stabilize on the eye and in its position. And I think what's kind of interesting about toric landing zones is that you don't necessarily have to put it in its proper position rotationally. These lenses will rotate to the correct spot, but the design should have indicator marks to designate where the landing zone is either steepest or in some cases flattest, depending on what the lens design you're using. And that's important actually, because there are times where you have to know the orientation of that lens on the eye, because that way you can communicate that position to the lab if you're going to add front surface toricity or a localized vault. They need to know where on the lens to put those additions. As well, just like with a spherical sclera, we can determine if a patient has a toric sclera by using profilometry or a measurement. This is a scleral elevation map of a patient with scleral toricity. And if we key on the outside there, on the sclera, we see these two areas of opposed blue color. And with sagittal height on scleral elevation data, the blue colors actually represent areas of increased sagittal height or steepness, whereas the warmer colors represent areas with less sagittal height. So this patient really has scleral toricity that runs in an oblique fashion. And then finally, the asymmetric sclera. And we said that those are about 65% of our eyes. We can determine asymmetry of the sclera using sphere or toric diagnostic lenses. Some of the fitting sets now actually also have quadrant-specific landing zone designs within the fitting sets as well. And so those can be useful, of course. And then, of course, we, as previous with the sphere and the toric, we can use software-based analysis to determine scleral asymmetry. And what we're really looking for is when we put a symmetric lens on the eye, whether that's a lens with a spherical landing zone or one that's toric, is we're looking for areas of isolated edge lift that are asymmetric or isolated areas of compression. And these types of fits may require a quadrant-specific or freeform landing zone design to achieve the best fit. Looking at a case example, this is a patient who had who had surgery, had LASIK surgery, left with some irregularity, and was best corrected 20/40. I did do a corneo-scleral topography on the patient, and what that topography was able to determine was that the patient had scleral toricity, but what we also saw is what we would call as a quadrant-specific effect. And I think if we look at the three-dimensional model of our eye, it's quite apparent that this quadrant-specific effect occurs nasally, where commonly the nasal quadrant of the sclera is generally flatter than what we see temporally. And so really this eye has asymmetry. And in fact, that really is highlighted and shows up if we put on a toric lens. So I actually fit her with a 200 micron toric landing zone. and she ended up failing. And if you looked at that image, that photograph to the right, we can see, as we might expect, that we're getting impingement at that area nasally where the sclera is flatter. And that's really what caused her to fail. So if we see this as we're fitting the patient using diagnostic lenses, we can flatten that area. We can have the manufacturer create a quadrant-specific flattening nasally, but we have to give them some information. And so what you need to let them know is, first, just the location of where we have the impingement or compression, the clock hours that we have a problem where we have compression, the approximate elevation, or as in this case, we had already taken a Corneo-Scleral Topography, so we can use that data to communicate to the manufacturer what modifications we need to make. So for this patient, we were able to quantitate that the landing zone out nasally needed to be flattened by 300 microns. And you can see this is the fit lens with the quadrant-specific design. We basically are able to create a nice even alignment across the scleral surface all the way around on the patient's eye. And this is just a comparison of the symmetric toric landing zone on the eye to the left, and then how much improved the fit is with the quadrant-specific design that we see to the right. It's quite striking. We also talked about isolated edge lift, and isolated edge lift is important to eliminate because that area of lift can be essentially an entrance port for the distribution up into the reservoir of bubbles and debris. So that's definitely something we want to eliminate if we see that. This patient shows scleral asymmetry with this inferior temporal edge lift. And we had taken corneal-scleral topography of the patient, and using that data, using those images, we're able to customize the lens to tighten down the landing zone in that inferior temporal quadrant. And you can see that we had a very nice result when we did that. So to the left, we have the lens with the spherical landing zone. And one great way to evaluate edge lift is just to turn your beam to the side, and really the edge lift will create a shadow. You can also use fluorescein, and fluorescein will uptake into that area. But to the right there, now we have the scleral lens with the customized landing zone, and we completely eliminate that edge lift, so you don't see any of those shadows. Well, another study that the Scleral Shape Study Group published just last year actually was looking at the relationship between the cornea and scleral topography in cases of ectasia. And this is important for scleral lens fitters because the primary indication for scleral lens use is ectasia or keratoconus. So for this study, we looked at 227 patients with ectasia and 150 normals. And importantly, we divided up the patients with ectasia into two categories: patients with central cones, or what we would typically call them nipple cones, and keratoconus with peripheral ectasias, or what we commonly would call as oval cones. And we measured both sclerotoricity and a quadrant-specific effect, or what we would also call asymmetry. And what we found was quite interesting. When we looked at the eyes that had central ectasia, those eyes really behaved like normals. So they had very little asymmetry. In fact, on average, only 66 microns, but they had a significant amount, a moderate amount of standard toricity. However, when we looked at the corneas, or the scleras, I should say, that had peripheral ectasias, now we see something quite different. In fact, actually, those eyes on average had significant amounts of scleral asymmetry. So on average, we have 289 microns of quadrant-specific effect for these eyes, and a moderate amount of sort of overlapping standard toricity. And what's even more interesting is that not only did the eyes with peripheral ectasias have more scleral asymmetry, but there was a pattern to that. And in fact, the ectasia out onto the sclera tended to be steepest. So where we see that model of our eye, what we see here is just what the study would have indicated, in that her inferior sclera is significantly steeper, in fact, by 300 microns in the same axis as her ectasia. Well, what happens with this is that if we put on a symmetric landing zone design, for example, a spherical landing zone design, these lenses tend to want to decenter where the sclera is steep. And so they sort of run downhill, if you will. And in fact, when we put a spherical landing zone lens on this patient's eye, this is exactly what we see. The lens is significantly inferior decentered, which can create not only issues of comfort, but also cause optical disruption. So for this patient, what we need to really do is we need to steepen the inferior quadrant, which is what I did, and we use software to do that. And so to the left here, I just have highlighted the limbus and the outer edge of the scleral contact lens, and we can see how decentered that spherical landing zone lens design is. For the lens on the right, what we did was we increased, or we steepened the inferior quadrant, and now we have essentially perfect alignment. So just by steepening that inferior quadrant, that oftentimes will help that lens to decenter, especially in a patient with corneal ectasia. And this patient was very comfortable with the lens, and she was able to see 20/30. In fact, we can hypothesize that she may have failed with the previous practitioner because they didn't take into account this quadrant-specific effect. Let me just offer some conclusions for this first part of the lecture, and then I'm going to turn this over to Jason. A lot of us, I mean, the vast majority of us out there fitting scleral contact lenses are still using fitting sets, and we can do that effectively using not only spherical landing zone designs, lenses within the fitting set, but also toric designs and also quadrant-specific designs. But there's really a big push towards using profilometry, which is measurement, and software-based assessment. This will more quickly and more accurately get you to where you need to be with a better fit lens. We need to fit more quadrant-specific or free-form lens design lenses to increase our success. And patients with peripheral ectasia will be best fit with increased sag in the same axis as the corneal apex. Okay, Dr. Jedlicka.
Thanks, Greg. So Greg's going to run the slides for me. So as we're ready to move forward, I'll just let you know when I need the next slide. So great talk, Greg. Appreciate all of the insight into scleral shape, and I'm 100% with you on all of that. I'm going to move just inside the sclera to the impact of the cornea shape and size on our scleral lens fitting, because I think that it's something that we tend to neglect. I think when we fit scleral lenses, one of the things we have to recognize is that we've got essentially two zones, and there's a zone of our lens that vaults the cornea and the limbus, and then comes to a point where it lands on the sclera. And then beyond that point, we have our scleral landing zone. So again, I think we've got these two zones, and what we need to do is we need to optimize how both of them work in order to get our lenses to fit optimally. But again, recognizing this concept of the corneo-limbal vaulting zone versus the scleral lens or the scleral landing zone. And different lenses are made in different diameters, and the sizes of these zones can be very different. We can have a lens that's got an 18 millimeter diameter, for example, that only has a 13 millimeter corneo-limbal vault zone. And I can have another lens that has a 13.5 millimeter corneo-limbal vault zone, and the lens is only 16.5 millimeters. So this is where understanding the designs you're working with comes into play. So let's go to the next slide. Again, understand your designs. Recognize you've got a base curve of that lens that carries the power of the lens, and is generally always going to be spherical. As we move out past the base curve to whatever you want to call these zones, but they're the peripheral cornea and the limbal clearance zones. Generally speaking, again, these curves are spherical in the vast majority of scleral lenses, not necessarily on our free forms or impression molded lenses, but on most of our designs. Everything that vaults the eye is spherical. And then beyond that, we land, and then we start to compensate for toricity in the eye as a whole with scleral landing zone toricity. And again, that's not necessarily where all of this toricity in the eye is found. Again, so there's a point in that lens design where the manufacturer intends that lens to touch the eye for the first time, starting from center and moving out. And that's a known diameter. That's something which the manufacturer should know, that diameter, and should be able to tell you that. And then the remainder of the lens is your scleral landing zone. Next slide, please. So again, thinking about lens diameter, when we choose a lens diameter, what's important? We need to pick a zone of corneal limbal vault which exceeds the diameter of the cornea and limbus. And whatever that is, we just need to know. So we need to be able to measure the corneal limbal zone, and then we need to pick a lens diameter where the vaulting chamber is at least that big or larger, but not too much larger, because that negatively impacts our fit. And then we have to recognize that the rest of the lens is our landing zone, and depending upon the type of eye we're working on, maybe we want that landing zone to be fairly broad and wide so that we get a very gentle land that's spread out over a larger area. And maybe in other cases we don't need that, and for various reasons of shape issues that occur at larger diameters, maybe we want a smaller landing zone so that we keep the lens inside obstacles or avoid increasing shape change. Next slide, please. So again, vital point number one here about lens diameter is you need to know that your corneal limbal vault zone of your scleral lens is greater in diameter than the diameter of the cornea and limbus at its greatest extent, recognizing that the limbus is not the same diameter in all areas. Most limbuses are have an oval shape to them. So you may have a cornea that is 11.6 millimeters in one meridian and 12 millimeters in another meridian. Again, we generally want to extend beyond the limbus at the greatest measured point, and then a certain amount beyond that. To ensure this happens, again, you need to know the size of the vault zone of the lens you're working with. Next slide, please. Again, vital point two is recognizing that this vault chamber, the area of the lens that clears the eye and is inside where there's clearance and where there's fluid reservoir, that is not necessarily directly proportional to the lens diameter. So understanding the relationship of the vault zone and the scleral landing zone and how the area of that lens is designated between the two zones is important if you want to choose a proper lens diameter for your patient. Next slide. So keep in mind a few facts. For most eyes, the temporal and nasal cornea is higher and larger in diameter than the superior and temporal cornea. If you look at that, that's just common. That's with the rule of astigmatism, right? If we have a patient who's got with the rule of astigmatism, we're going to see a higher point at 3 and 9 where that lens is going to first land on the eye than at 6 and 12. The elevation difference, generally speaking, is going to hold through the limbal zone, although much of the shape change that's going to occur in an eye starts to happen in the limbus, but that shape change then continues through the sclera. And so again, what ends up happening in most lenses, even lenses that are toric or quadrant specific in their scleral landing zones, the internal zones are spherical. And so we don't end up with a lens that lands evenly at its initial touch point on the eye. So at the beginning of the scleral landing zone or the ending of the vault zone, we're not touching the sclera evenly throughout the entire lens diameter. Go ahead and move up one. I think there's another picture here, Greg. Sorry, thanks. So what we end up with again is, if you can look at this picture, if you look at the width of bearing at 3 and 9 and the amount of limbal clearance at 3 and 9, you can see that we've got the fluorescein extending out further at 6 and 12, which shows us again that the eyeball at the landing zone of the lens, where it first touches the eye, is got two different elevations. It's higher at 3 and 9, it's more depressed at 6 and 12. And so our lens is landing farther away from the limbus, or it's clearing the limbus greater at 6 and 12. And it has less area of contact between the eye and the lens at 6 and 12. And what ends up happening then is that lens is going to decenter inferiorly, and it's going to slide down and drop. So next slide, please. Here's just a couple pictures of some scleral topography. And what I really want to draw your attention to is, if you look at the top picture, we've got an eye which perhaps has a little bit of scleral toricity, where we look a little bit more elevated around 3 and 9, and a little bit more depressed or steeper up there around 12, 1 o'clock, and down again around 7 o'clock. And so you'd say there's a little bit of toricity in the sclera. But when we think about the shape of the eye and the toricity, most of the time we think about the toricity of the eye as a whole at the end of the lens diameter. So if I was fitting this eye in a 16 millimeter lens, I might be talking about the difference in shape or elevation between the two major meridians at 16. But the reality is, again, that much of that difference in elevation occurs inside the point where the lens is first landing on the sclera. Some of it's coming from the cornea, and yet we don't compensate for that in the vast majority of standard fits. If you look at the lower picture, what you see is much more scleral toricity at about 4 and 10 o'clock there. And if you look at the printout, the numbers next to the lower two maps, these are at a 12.8 millimeter chord diameter. So this is about an area where most scleral lenses are going to first touch the cornea, if the cornea is, let's say, average 11.8. And at that landing point, if you look at the very bottom numbers, it's going to say the minimum sag at that diameter is 2.78 millimeters. The max is 2.97. That means that at a 12.8 millimeter chord, the elevation difference in this eye is nearly 200 microns where the lens first touches the sclera. So that's going to create a significant misalignment in your zones, even if I compensate for it at the end of my scleral zone. How do we deal with this? Again, this comes into the aspect of adding toricity to our lenses internally to the point of first landing. And so as you go back to some of the diagrams we looked at earlier that show the base curve and then a couple more zones of curvature before we land on the eye, we probably need to be thinking about, if we're going to optimize the fit, adding toricity in those intermediate zones to get the lens to properly touch the sclera at an even point all the way around the eye. Next slide, please. So again, what ends up happening sometimes is we end up with excessive or inadequate vault in one sector or over the entire eye. And so understanding what this amount of limbal clearance can or does do to our fits. Excessively vaulting the limbus really is never a good thing. It adds a space for prolapse to occur. It probably creates some more risk of limbal hypoxia because we have so much more clearance. It adds to decentration problems. So over vaulting the limbus almost always ends up becoming a problem. Next slide, please. And here we see some complications of excessive limbal vault, excessive limbal clearance, either in terms of too much elevation over the limbus or the lens landing way too far past the area of the limbus and therefore creating, again, a significant area for vaulting and for lens clearance to occur. We see on the left this massive amount of prolapse. We see on the right this limbal edema. And we see again on the right a very narrow area of landing of that lens. You can see because it's blanching a little bit. But inside that area of blanching, you've got just clearance. And that's a lot of eye where we've got a lot of vault where we don't really need it. And this is creating this poor fit. It's creating this limbal congestion and ultimately this hypoxia that's driving this vascularization. Next slide, please. So again, choosing a lens diameter that has inadequate limbal clearance. So choosing a lens which is too small for the eye, where perhaps the cornea is 12.5 millimeters, but my corneolimbal vaulting zone is only 12.4. And so I'm really landing on the limbus or peripheral cornea. And all the tweaking that I can possibly do with that lens in the limbal clearance zone isn't going to make a bit of difference because my limbal clearance zone is inside my limbus. So I may be adjusting that zone and I'm really not creating any positive effect. What happens when that occurs is we get these areas of broad, insufficient limbal clearance like you see in the picture on the left. When that patient wears that lens all day long, we take the lens off and we see these epithelial bullae, not from hypoxia because there's plenty of oxygen getting through there, but the mechanical pressure on the eye from the lens pushing on that area creates these bullae. And again, the only way to fix this is to simply go to a lens with a larger corneolimbal vault zone, which usually means a larger overall diameter. Next slide, please. Again, don't confuse the issue on the left with a picture on the right here, where we've got a small sector of touch. And if we simply push that lens up into a centered position, we see that touch go away. That picture on the right does not need to be dealt with by increasing limbal clearance in any way, shape, or form. It needs to be centered better, and that limbal clearance will then resolve itself. Next slide, please. Again, the picture on the left, we can see this lens is decentering inferiorly, and it therefore creates this superior limbal touch. And so one of the ways that people may try to compensate for this is to say, well, I need to increase limbal clearance because I don't want to bear on that limbus superiorly. And of course, what happens then is it just makes our fit worse. It makes it even more decentered, and it doesn't resolve the vault. The picture on the right shows that very same lens just pushed into a centered position. And now we can see we actually have plenty of limbal clearance. We've just got an area where we don't have enough touch or area of contact between the sclera and the lens to hold that lens into a superior shape. So we need to resolve it by other means, but not necessarily increasing limbal clearance in these cases. It just points out the fact that, again, we really need to always be looking at a lens into a centered position, push the lens into a centered position when we want to evaluate how to resolve our problems. Next slide, please. And just one more schematic here to wrap this topic up. Again, you can see a picture on the left. This lens is decentering inferior temporally, creating this area of superior nasal limbal touch. When we evaluate this, when we have the patient look down, it looks like, gosh, we've got a pretty good fit. The picture on the upper right shows, looks like the lens edge is really nice. But when we have that patient look into a straight gaze and reassess that area, we see now edge lift starting to form. And so this just drives home the point again, when you're evaluating your limbal issues, when you're evaluating lens diameter and such things as this, make sure you're evaluating that lens in primary gaze as much as possible. Looking off gaze, up, down, left, or right is going to change the lens position. It's not going to be truly representative of what you've got most of the time when the patient's in primary gaze. So last slide here, I guess. Just some take homes again. Lens diameter, make sure that you understand the lens designs you're working with, what that corneal limbal vault zone size really is. So you make sure you're clearing it with just the right amount of clearance, not excessive and yet not inadequate. Choose a diameter the patient can work with. Know that working with larger corneas and smaller apertures can certainly be more challenging as we need a larger lens for clearing, and yet we trying to fit it into a smaller aperture. So just some things to think about. And again, I think as we move more towards, as Greg mentioned, these customized freeform quad specific, I think we're going to see more adding toricity or quadrant-specific effect also into the internal aspect of the lens inside the scleral landing zone and into those intermediate zones to try to improve the fit as well. So Greg, I'll turn it back over to you for the last little section here.
Thank you, Jason. All right, so we want to end this lecture talking about scleral obstacles, and I'm going to start off by just discussing pingueculas, because certainly that's the most common obstacle that any of us would see. We of course routinely fit over pingueculas all the time with soft contact lenses. Not a big deal because they're soft and they are able to vault over those pingueculas with no problem. Depending on the elevation of the pinguecula, sometimes we're able to land a scleral lens landing zone onto them without complication as well, as we see here in this photograph. However, as an elevation increases, as the pinguecula is larger, then we do reach a threshold where it can create a complication, and that complication is generally impingement. And the micron threshold that will usually cause this is similar to the threshold we talked about before with our different landing zone designs, and that's 200 microns. And so if we have a pinguecula that's 200 microns or more, typically this is going to create a problem in that landing zone area. And impingement of pingueculas really leads to irritation. It can cause the patient to not be successful because of that. It'll decenter the contact lens, and it'll also create proximal edge lift, which, as we talked about before, can be a port for bubbles and debris. So we definitely want to try to eliminate impingement on pingueculas as much as possible. Just looking at a case example here, this is a 58-year-old female patient who I saw who had a previous radial keratotomy. She'd actually had previous pinguecula surgery. Her best corrected visual acuity is 2050 and 2040. We did and took a Corneo-Scleral Topography, a map of her anterior ocular surface, and what we could see here is this elevated spot nasally that corresponds with the slit lamp to a nasal pinguecula. And the nice aspect of Corneo-Scleral Topography is that we can precisely quantitate the elevation of the pinguecula. In fact, it measured 250 microns of elevation. And just like we might expect, talking about that threshold, if we apply a spherical landing zone, a scleral lens on the eye, then we definitely get impingement like we see here. Now, there's several ways that we can address this issue. One is to decrease the overall lens diameter. We can also create a potential notch to bypass the pinguecula, or what we're going to talk about for this lecture is creating a localized vault. Now, if we're doing this using diagnostic lenses, for example, a scleral lens with a spherical landing zone, then just like when we were designing our quadrant-specific lenses, we have to communicate some parameters or some measurements to the manufacturer. And so that includes the location of the pinguecula, the clock hours of impingement or lift of that lens off the pinguecula, the width of the contact between the lens and the pinguecula, the elevation height, and if you have to guess, 200 microns is a good place to start. And then I also want to point out that we do have to create a lens with rotational stability. And so if we're using a spherical landing zone design, it'll have to be ballasted just like we ballasted for front surface toricity. Or more ideally, we would ballast it with back surface toricity or a quadrant-specific design. For this patient, we had Corneo-Scleral Topography. The patient actually had scleral toricity, so the landing zone design was Toric, which allowed the lens to have even alignment and rotationally stabilize the lens in its correct position. And we created a localized vault. And the manufactured lens we see here to the left, in fact, you can see really the lip of that vault. And then when we place that on the eye, it really nicely vaults over the pinguecula without the impingement, and it's rotationally stabilized with the customized back surface landing zone toricity. This is the eye. This is the scleral lens on the eye, and I always think that the best fitting scleral contact lenses are ones where you can barely see the lens on the eye, which is really what we have here. Now that black dot there is the indicator dot, so the patient knows where to position that lens on application so that the localized vault is in its correct position. The other common obstacle that we may see in our clinics are conjunctival blebs, and those occur usually after glaucoma surgery, in particular tuberculectomy. And for those obstacles, we can create a localized vault like we did with pingueculas. And I think that's generally in my practice preferred, especially if we're using software-based analysis from prophylimetry. But we can also create notches with the lens. And I think that's probably preferred if you're using diagnostic lenses. And we'll go through a couple case examples. For this first patient, this is a 7-year-old patient with a corneal transplant. He also has, unfortunately, has significant glaucoma and had a trabeculectomy and has had some vision loss from glaucoma. And this is his graft and his bleb looking a bit in down gaze. And I just want to point out that I think it's important when we're looking at these eyes and we're going to use a scleral contact lens, that a little bit of space between the limbus and the bleb actually really will help us with the scleral contact lens fit. And that's as opposed to what we see here to the right, where we have a fairly sizable bleb and it's overhanging the limbus. And these will be near impossible to fit with a scleral contact lens. And so for this patient, I'm going to highlight the lens here. We ended up opting for a corneal lens for that patient. But for our patient, we did have a little bit of space, as you could see. And so we were able to use our corneal topography measurements along with software design to create a very highly customized scleral lens. And that lens you see to the right there was 16.5 millimeters in diameter. It had a asymmetric or customized landing zone that created alignment along the bulbar conjunctiva scleral surface and also provided rotational stability. We had a 900 micron localized vault manufactured into the lens. This is the lens on the eye. I'm going to highlight the edge there, and you can see how nicely it's fitting on the patient's eye. Here's another look without any compression. That 900 micron vault really vaults over that bleb. Well, as I said, we can also use lens notches. So here's a patient with a very sizable bleb, also a patient who had a corneal transplant. The scleral topography is to the right there, so we can really measure the bleb, its elevation, its width, and also this patient, as you can see, has scleral toricity that we'll incorporate into the lens design. Now, if you don't have prophylometry available, if you don't have Corneo-Scleral Topographer or Scheimpflug instrument, or using impression-based technology, something that I used to use before I had prophylometry would be using and having diagnostic lenses with pre-cut notches in them that you can use diagnostically. So if you're seeing a fair amount of these and you don't have ability to measure the sclera, this is what I'd recommend getting from your manufacturer, and have a couple of these to use clinically. For this patient, we were able to use the measurements from topography to not only know the size of the notch, but also to incorporate the back surface toricity onto the lens. This is the lens in place here. Basically, the patient does have to put this lens on like a puzzle piece so that the notch matches the location of the bleb. We want to decrease the diameter a little bit on these lenses, so that effectively allows us to lessen the amount of bevel notch that we have to make to bypass that bleb. And that patient did quite well, included a toric landing zone. So just some key points of discussion for obstacles that we have to deal with scleral contact lens fitting. From pingueculas, I think really, for the most part, the preferred method is using a localized vault. 200 microns is a good place to start if you're unsure of the elevation. And these lenses do have to be rotationally stabilized. For blebs, we can use localized vaults as well, or notches. That may be preferred if you're fitting from diagnostic lenses. And certainly we want to really monitor those patients a little more closely to make sure that we're not creating any complications with their glaucoma. Well, thank you very much. And I think that Drew's going to get back on here and maybe address a few questions.
Yeah, thank you guys so much. Fantastic lecture. I want to start with Dr. DeNaeyer. You cut out temporarily back a number of slides ago in your first section where you were talking about how the steepness of the sclera relates to peripheral ectasias and findings. Familiar with that? Did that ring a bell? And if so, can you kind of go back over that for us?
Yeah, no problem. But what we found was that patients with peripheral ectasias, so patients with oval cones, tend to have scleras that are very highly asymmetric. And there was a pattern to that asymmetry. And in fact, the sclera is generally steeper in the same axis as the apex of the cone. And so since the majority of cones are inferior, most of the time the asymmetry that we're going to see is a pattern where the sclera is going to be steepest in the inferior quadrant.
That makes sense. Can one of you talk a little bit about compression rings that are seen upon removal of the scleral lens, when to be worried, and assuming that the haptic alignment is deemed proper?
Go ahead, Greg.
Yeah, so I mean, you know, the bulbar conjunctivis, which is really what we're landing the sclera on, is this very spongy surface. And I think even, you know, even with a perfectly aligned lens, we're going to have some compression of that tissue. And so when we take it off, you might see some impression ring. In fact, we can measure that with Corneo-Scleral Topography as well. But it's really nothing to be concerned about per se. Usually that will rebound very quickly. And most importantly, it's your evaluation of the lens on the eye. And so as I was showing that video earlier, you know, the best fit lens that's on the eye surface really looks like there's no lens on at all. And so that's what we're trying to achieve.
Yeah, and I think if you have a compression ring that's associated with redness or irritation, I mean, those are a little different than just an isolated finding that, gee, doc, when I take this lens off, I can see an imprint where the lens was for 20 minutes or something. But no other findings, then I'm not concerned as much about that.
You guys did talk about this already, where there are a number of questions about conjunctival prolapse. How much is acceptable, and what are some remedies?
Yeah, I mean, to me, I'd rather not see it. And so if I look at a fit and I think that there's an easy remedy, that I can see an issue with the fit that I can fix through adjusting some curves, I'm going to try to fix it. Now, that said, if I have a patient who's got some and they're perfectly happy and loving life, and I don't see an easy remedy, I may just monitor it. If it stays white and quiet, if the prolapse is just, you know, billowy white conj, if the cornea that underlies it when it comes in is quiet, I may just watch it. I'm more concerned when that prolapse looks inflamed or red or hot, or the cornea underneath it looks the same. Then I'm bothered, and then I would resort to doing something to remedy it if I could.
Beautiful. And then when it comes to lens stabilization via toric haptic, is there a certain amount of toricity you like to have without having to worry about rotation?
Yeah, I think just getting back to that threshold is that if you have, this is based upon my experience, if you have at least 200 microns of difference in those two primary meridians of a toric scleral surface, that lens will lock in place pretty easily. So less than that, I mean, you might be able to get a lens to stabilize. I mean, there's a couple other variables in that equation, but 200 microns for sure, you're going to be able to have a lens that locks nicely in place.
Yeah, and I would say that I would go down to, you know, if I looked at my map and I saw that I had an eye with even 100 microns of toricity, but I knew I needed a front toric optic, or maybe I had a pinguecula I wanted to locally vault, I probably would go back toric down to as low as, you know, 100 to 120 microns, assuming that that would probably be enough to stabilize it. Below 100, I think it gets pretty hard to guarantee that it's going to stabilize.
And then we'll do one more. We had a question about fitting smaller corneas, hyperopes, really shallow eyes. Any advice on diameter suggestions or starting points?
I mean, I think that, you know, if you're fitting scleral lenses, you're working with a lab already or a couple labs. And I think that if you communicate to your consultants what you have going on and point out the fact that you're working with a fairly small eye, small cornea, whatever, and you'd like to, you know, have them help you come up with an optimal lens diameter that's going to work for that eye best. You know, I would hope that the consultants would be able to steer you, knowing that they know the lens design, the internal specs, and that they could drive you to the proper diameter to get that lens to fit right.
That's perfect. There are a few more questions. They're not exactly pertinent to the current lecture, but you do see the email addresses of the two presenters tonight. If you want to forward some questions their way, I'm sure they would be more than happy to answer them for you. Again, thank you to our presenters tonight. Thank you all for coming out. Please be safe, and we will see you next time.